Good afternoon. So, the topic for today's discussion is perception and its disturbances, a very important topic from the point of theory as well as practical. It's a basic slide, which something which you already know, but in detail we'll be seeing what exactly is perception and what are its disturbances and how we evaluate it. So, we'll be covering it under the following headings. Starting from the introductory part, what is perception? It is the process by which our brain interprets sensory information and it gives a meaning to that raw information which is being interpreted. There are several steps wherein we recognize the stimulus, we organize it into a meaningful structure and then give it a meaningful context. Uh, and association with memories and past experiences also something which comes into play. For example, when you look at a tree, what you see, if you see the raw structure will be, you'll see the color, you'll see the structure, you'll see the shape and size. After the process of perception, your brain will see it as a full image of a tree and you will perceive it as a tree. Similarly, sensation is something wherein it is the first process step in the process of sensing the information, wherein the sensory organ detect the physical stimuli from the environment and that is converted into a neural signal that are then sent into the brain. It is the initial stage of processing that occurs when the sensory organ responds to an external stimuli. For example, when you touch a hot stove, the sensation of heat and pain is detected by sensory receptor in your skin. These receptors sense the signals to your brain and you get alert towards the heat. So sensation, it provides the raw data like it is hot, it is cold, it is bright, it is dull kind of data. Just a brief difference. Sensation is a process wherein the brain receive input from the sensory organ, wherein the perception is a process where a sense is made out of the input which is being received. It has been converted into something meaningful context. Another word is imagery. Imagery is something where external stimulus is not present, but it refers to the mental representation of sensory experience which has happened in the past. It involves recreating sensory experience in the mind, often through visualization, imagining sounds, smells, or sensation. For example, you can imagine that you are in a beach, you can imagine the color of the sea, clear water, you can imagine the color of this bright blue sky, some clouds, you can imagine there is sand, and you can imagine trees around. You can even imagine the sound of the waves. So without being present on the actual beach, this is something you can imagine. So difference between perception and imagery. In perception, interpretation of sensory information is there from the environment, whereas in imagery, it is the mental representation of sensory information. No external stimulus is required, whereas in imagery, in imagery, no external stimulus is needed. A real sensory external stimulus is needed in perception. Involves the process of actual sensory input, again the same thing, wherein the recall of the information which you have had in the past based on memory or thought. Perception is said to be more accurate because you are seeing the because you have the actual sensory stimulus there, whereas imagery can vary in accuracy. There are different steps in the process of perception. How do we perceive an object? It starts with the process of sensory reception, wherein the stimuli through the sensory organ is detected. Then this stimulus is converted into neural signal by the process of transduction. Transmission is something where neural signal is transmitted to the brain, and in brain the organization, a meaningful pattern is being made of sensory stimulus. Then based on context and past experience, the stimulus is interpreted at what actually it is, and again following integration with memory and giving context, you became fully aware of the stimulus. Just for an example, when you see a red apple on a table, the perception begins with sensory reception where light reflecting of the apple enters your eye, you detect which is detected by photoreceptors in the retina. Now this is converted into electric signal through transduction which can be read by the brain. Through optic nerve it is carried to visual cortex where this is through the process of transmission where initial processing begin. Now wherein the organization part, the color red, the round shape, the edges which are present in the apple, it is being differentiated as a different object than what it is lying on, that is the table. And through interpretation, brain recognizes feature based on past experience. You might recognize this is how the color of the apple, how it tastes, and whether to use it as a snack, whether to use it or eat it or not. So finally, you become consciously aware of the apple. So a raw data of a round object which is red in color, certain texture, certain shape is seen by you, and it is processed as a something which you can eat, that is an apple. All right. So there are several factors which can affect the perception. This factor can based on the target which you are seeing. It can based on the perceiver, that is you, and the situation. For example, time, work setting, social setting. If you are seeing a dark object at night, it will be very difficult to perceive it. Similarly, sometimes you are in a very crowded space, you might have difficulty hearing the particular sound. So this is how the work and social setting differs. Similarly, if you're going through certain what we call stressful situation, you have certain interest in, so if you're not interested in seeing or hearing something, the these are the certain factors in the perceiver which can affect the perception. Again, if a target is moving, if it is a color is very dull, if the background and the current color is vary in contrast, there could be difference in perception. All right. So based on the types of sensory modality, you all know perception can be of various types. It could be visual, wherein the recognition of shapes, color, distances, movements can be there. Auditory perception, based on the that is something you can hear. It interprets sounds. It could also be sound waves for about pitch, loudness, tone, and rhythm. Tactile perception is something which involves the information through physical contact of object or surface, which can include temperature, pressure, texture, and pain. Olfactory perception is smelling something, and gustatory, tasting something. Proprioception, often called sixth sense, based on the body position, movement, or sometimes we also call joint position sense, which can helps in maintaining balance. Time perception, being aware of the interpretation of the passage of time. There's something called social and environmental perception as well, based on social setting, like recognizing a familiar face, recognizing a good, giving a familiar smile to a familiar face. So this is something based on social and environmental perception. So now till here perception part is clear. So we'll move on to the disturbances of perception. It could be divided into two parts: sensory distortion and sensory deception. Sensory distortion, wherein the stimulus is present, there is no change in the stimulus per se, but the change in intensity, size, shape, and quality of sensory experience can occur without any real change in the external stimulus. For example, macropsia and micropsia are the process wherein the object might appear larger in size or may appear smaller in size, generally associated with neurological condition, visual pathway disturbances, or temporal lobe dysfunctions. Dysmegalopsia, here the change in the structure and shape of the object occurs. Again, neurological condition or certain hallucinogenic drugs are associated with change in structure or shape of the object. Now, based on intensity of sensitivity towards sound, hyperacusis and hypoacusis are two phenomena. Hyperacusis is increased sensitivity to sound. Often you can see in patients of migraine might complain. Sometimes patient of PTSD, especially war patients, war Jones patients are coming. They might say that certain voices triggered them, certain voices feel very much amplified to them. Similarly, hypoacusis is something mostly seen in neurological condition or certain kind of hearing loss. Then you can have disruption in tactile distortion, changes in the perception of touch, including feeling of numbness. Most of the time, patient of depression might say, I don't feel anything over my skin. Patient of personality disorder, sometimes borderline personality disorder also can say, I do not feel touch and any kind of pain sensation. There could be hypersensitivity of sensation, and there could be hyposensitivity as well. Again, somatosensory cortex is here, which plays the role. Time perception, as you all know, in depression we can say that time is passing very slowly, whereas certain psychedelic drugs have a certain influence on time. Next term, derealization, is the distortion of environmental perception, making the surrounding feel unreal, dreamlike, or distorted, often seen in dissociation, PTSD patient, or anxiety patient. Next is sensory deception. Deception involves false or misleading perception that occur without actual external stimuli. Again, primarily it is of two types, hallucination and illusion. We'll shortly see what are illusions. These are misinterpretation of actual external stimuli. Illusions are, unlike hallucination, the real sensory input may be present, but it is perceived inaccurately. Further, it can be divided into affect illusion, pareidolia, size illusion. So these are something which can be there. So what are the mechanism? Again, stressful condition, something, suggestibility is something which can affect. We will try to fill in the gaps or make assumption without of the ambiguous stimuli. Like, although the severity might not be that of the level of hallucination, but it is also something which can cause distress in the patient. All right. Now we'll move on to the important topic, that is hallucination. You all know that hallucination are the sensory perception that occur in the absence of an external stimulus and which are perceived as real by the individual. There is no external stimulus, but still it will be perceived as real. Hallucination can affect any sensory modality, including auditory, visual, tactile, olfactory, and gustatory senses. प्लीज मेक श्योर अगर आपको एक मोडालिटी में हेलुसिनेशन मिल रहा है तो ऑल्सो एलैबोरेट कि किसी और मोडालिटी में है कि नहीं. Most of the time what we do, we examine auditory, we will forget about visual, tactile or other form of hallucination, although you might not find it, but it is your duty to check for other modalities as well. Moving on, starting from auditory hallucination, most common kind of hallucination involves hearing sounds such as voice or noises without any external stimuli. These are the most common type of hallucinations, especially in schizophrenia and mood disorders. Now, based on type, they can be elementary or complex. Elementary are unstructured sound which lack any linguistic or meaningful content. They are simple. They could be like buzzing, clicking, whistling, or even a humming sound. Patient may describe them similar to tinnitus, but generally what happens, they will be of external origin in comparison to tinnitus. Apart from psychiatric disorder, epilepsy and auditory impairment are something where the elementary hallucination can be seen. Next is complex auditory hallucination. Now they are more structured sound. They could be voices, noises which have a very distinct linguistic content. They can have with individuals hearing full sentences or multiple voices. They can originate inside or outside of the head, and then content can be perceived as judgmental, supportive or commanding. We'll go through it one by one. Something very much specific to schizophrenia, commentary voices. Individual hear voices providing a running commentary to their action. Now, very common in schizophrenia, and often voices seem to criticize or judge the individual action, amplifying the feeling of paranoia or self-consciousness. Now, types based on the what you see: first person, second person, third person hallucination. First person auditory hallucination refer to a type wherein the hallucinatory voices seem to echo the thought of an individual, but the person will experience them as an external sound rather than their own internal thought. OTP, Oxford Textbook of Dictionaries, Psychiatry says that it could be of two types. It could be Kidden Can Lot Worden, wherein the thoughts and the voices are simultaneous to each other. Patient's thought as he is thinking to them. I am thinking and the thoughts are also coming. And another is Eco de la Pense, which immediately after, not simultaneous, but just after the thought has finished, the echo of that thought is lessened. Okay, this is called echo de la Pense. You'll find it in your textbooks. Don't worry. Second is second person auditory hallucination, which involves speaking directly to the individual, often in a derogatory or accusatory manner. And in third person, they may talk among themselves, referring to the patient as the third person. They're talking about individual in the third person as if they are not present. Very much specific to schizophrenia, it increases the paranoia of being watched or being persecuted in the patient. All right. Very important, command hallucination. These involve voices which gives direct instruction to the individual, which may be harmful or may be benign. It can range from simple tasks to being encouraging self-harm or harm to others. So this is something you should be very careful about while you are examining the patient, and this is something which require immediate attention. They may feel compelled to follow the command, especially if the voices are persistent and authoritarian. Next, we'll move on to visual hallucination, most commonly associated with organic brain disorder or substance-induced conditions, wherein the patient may see object, people, light that are not present. Okay, they are little less common than auditory hallucination. Again, they could be again simple and complex. Simple visual hallucination may you may see light, colors, geometric pattern, flashes of light, like aura of the migraine or in epilepsy, patient might say. Similarly, like complex auditory hallucination and complex visual hallucination, patient might see full formed images such as people, animal, object or entire scenery, delirium being one of the most common conditions. Okay, next is your tactile hallucination. Tactile hallucination, in visual hallucination, the example being Lilliputian hallucination or picking up behavior that you see in delirium patient in elderly. In tactile hallucination involves the sensation of touch or movement on the skin without any actual contact. Common in substance-induced psychosis that are often associated with like cocaine or other stimulant drugs. Formication is one of the specific term given to the tactile hallucination, wherein the person feels some insects are crawling, and in response to that feeling, patient might itch himself, might pick his skin up. Okay. The term is cocaine bug, crack bug, or sometime in meth users, they may have something patches in their skin that is called meth patch. They might peel their skin off, or they might scratch their skin off because of the feeling of certain thing crawling under their skin. The sensation is often accompanied by intense itching or pricking, which can lead to scratching, skin damage, or even infection. Just an example of what is formication. All right. Now, some people might say hallucination of bodily sensation is similar to tactile hallucination, although Sims described it in a different subheading. So, they are further of three types. First is your superficial hallucination. Just on the superficial level of your skin, you will feel that there is something present. It could be temperature. You might feel that I feel something hot or cold under my skin, which is called thermic superficial hallucination. Haptic is that of touch. Somebody touched me. It could be light touch. It could be deep touch. And hygric is something patient might say कि पानी भर गया मेरे शरीर के अंदर या जोड़ों के अंदर. Presence of certain fluid. All right. Next, in the part of superficial, next to superficial is kinesthetic. Here it involves a sense of movement in the body or limb without the actual movement which is occurring. Often the hallucinations are associated with disturbances in proprioception. Okay, for example, a 55-year-old patient with schizophrenia reports that my arms and legs are lifted up in the sky despite he is sitting still in a lying down position, no movement is being there, but there is that sensation that his body is being moved. Next is visceral hallucination, wherein the internal organs are involved. Do not confuse it with somatic delusion. Okay, here the feeling, that sensory feeling is present. These hallucinations may include sensation like abdominal twisting, heart pain, or intestinal movement. Patient feeling his intestine being tightly twisted, like tied into knots. Despite all the medical examinations showing no physical abnormality, he still believes that there is sensation wherein his organs are being taut up, not up, sorry. All right. Next, we have olfactory and gustatory hallucination, commonly seen in epilepsy patients. Sometimes the patient of schizophrenia might complain that he's smelling foul smell from the food. So one of the very, though less, but early symptoms which we can see in patients of schizophrenia. Then certain uncommon but certain different type, hypnagogic and hypnopompic, something you all know. When patient one who is going to fall asleep is hypnagogic, while waking up, mostly auditory and visual hallucinations are more common in hypnagogic and hypnopompic hallucination. Another thing is autoscopy. Autoscopy involves the phenomenon of seeing oneself, that is, one's own body double is being seen. Patient might say it is like a ghostly experience for us. It is further subdivided into five categories: autoscopic or positive autoscopy, wherein you see your body double. Heotoscopy is something where the boundary between body double and self is little blurred. Patient feels that I am present in both. I am present in body double as well, and I am present in myself also. But which am I? I am a little bit confused. Feeling of presence is somewhere something where, although this nothing is visualized, but patient might say that मेरे आगे पीछे कोई चल रहा है. शायद मैं ही अपने आगे पीछे हूँ, but मुझे दिखाई नहीं दे रहा है वो इंसान. But there is a presence of someone. All right. Out of bed experience, something you might have seen in certain TV series, or the patient of near death experience might say कि मेरी मैं अपने शरीर से बाहर निकल गया था, and I can still feel कि certain things are going on in my body, and I can see from above that my body is lying down, the people are moving its hand and legs. Negative autoscopy, you cannot, one will say कि I cannot see myself in the mirror, something dissociation के patient might complain quite a bit. So autoscopic hallucination, heotoscopy, out of body experience, and negative autoscopy. Next is extracampine hallucination. Uh, Hallucinations are of things that and events outside the range of normal sensory experience. This is something we have discussed before also. For example, a patient of schizophrenia hears a voice calling their name from a faraway location, from a different street, maybe from a different city, and but he's saying I can hear that they are plotting against me, even though there is no one around. Next is functional hallucination, wherein the hallucination when a real sensory input in one modality triggers simultaneous hallucinatory experience in the same modality. Okay, just see, a patient of schizophrenia reports every time the church bell rings, the voice he hears a voice criticizing him harshly. Okay, saying the things like you are worthless. This hallucinated voice occurs exclusively with the sound of bells and stop once the ringing has stopped. Okay, there is an external stimulus of the same modality actually present, but simultaneously that stimulus activate the hallucinatory process in the patient. Next is your reflex hallucination or synesthetic hallucination, when a stimulus in one sensory modality induces hallucination in another, most commonly seen with psychedelic drugs. Person with reflex hallucination sees a flash of light and simultaneously experiences the sensation of hearing music or voices. The light itself does not produce any sound, but the visual stimulus triggers an auditory hallucination. All right. Now, next is something which is called pseudo hallucination. These are sensory experiences, though they resemble true hallucination, but differences patient might recognize them as unreal or as a creation of their own mind. Unlike hallucination, which are perceived as real and external, pseudo hallucination may feel internally generated and are typically less vivid than true hallucination. For example, a 35-year-old woman with a history of PTSD reports hearing a critical voice inside her head commenting negatively on her action. She says that this voice is in her head, and if she is thinking the words rather than hearing them spoken aloud. She is fully aware that no one is actually saying these things to her and recognizes the voice as a product of a trauma-related thought. However, the voice is persistent and it causes distress in her. See the difference between pseudo hallucination, hallucination imagery, certain time it becomes very difficult. So this is one of the example which I find quite close by to explain to you. Just few differences. Although the hallucinations are originated within, but they are most of the time misinterpreted as the external source, whereas pseudo hallucination and imagery originate within self. They are in outer objective space, and imagery and pseudo hallucination are inner subjective space. In hallucination, most of the time insight is absent, whereas in pseudo hallucination and imagery, it is present. Although it can occur, everything can occur in all the modality, pseudo hallucination and imagery are more common in auditory and visual sensory organ, sensory modality, whereas in hallucination can occur in any of the modality. Hallucination are more common, clear, and pseudo hallucination can also be clear, but the clarity in imagery, since it is based on a recall and a memory, is little less. Behavioral relevance is present in both hallucination, though less severe, but present in pseudo hallucination as well. In imagery, not required. Hallucinations are not under the will, pseudo hallucinations are also not under the will, whereas imagery can be under the will. All right. Now, very important, how do you evaluate the hallucination? This is something you should know, both in history and examination part. You should be very gentle in asking the patient about any unusual sensory experience to create an open environment for discussion. They can be distressing. Patient may see that there is stigma or disbelief among the other individual. So just a simple question, like sometimes people go through experience where they see or hear or feel the things that others don't. Do you experience any such thing? Has any such thing happened with you? Certain direct questions sometimes can help. Access the modality, of course, in which modality it is, in auditory, visual, or tactile. Like, do you hear voices or sound when no one else is around? Then moving on, once the modality is clear, then you will move deeply into the content of all the hallucination. Determine the source and location of the hallucination, whether they are coming from an outer external world, or whether do you think they are in your mind, or whether it is some place close by to you, or it is coming from a far away distance. So this, if you find out the source and location, you might be able to differentiate whether it is pseudo hallucination or hallucination. Then you move on to the description of the experience. You have to see the content, the frequency, duration. We'll see one example later on. Intensity and clarity of hallucination. For examining the details like clarity and tone and volume of auditory hallucination. In visual hallucination, whether it is there is any movement of the figure or not, and whether it is clear, whether it is in contrast to certain uh, drug use or not. Okay. For auditory hallucination, it is important to clarify if they involve commentary, command, or conversation. Determine if the context is consistent or varying, coherent or not, whether the voices they are hearing is very clear and complete sent or just a fragment of few words. Then a specific environment or trigger pattern. Do you experience when you are alone or stressed? Do you experience them whenever you consume certain kind of substance or not? So this is something which should be um, monitored. Then emotional and behavioral response of the patient. Emotional response can reflect the distress caused by hallucination and can be crucial for risk assessment, particularly for command hallucination. Behavioral responses like talking back, active listening. Sometimes patient may stoop forward or give a ear to listen to the voice, or may search for the speaker from where the voices are coming. Moving away, may try to move away or able to exercise control over the voices or not. Access the insight of the patient, whether they believe it is just within their head, or are they sure that these voices are real and they are there to harm that person. Whatever they see is real and it is of certain significance. Poor insight is associated with more acting out on hallucination. Determine if the patient recognizes the hallucination as unreal or believes them to be real. The patient lacks insight into the unreal nature of the voices and believes they are from higher power. Patient with poor insight are at a greater risk of acting on their hallucination, especially if they involve command or paranoid themes. So, just a brief example, a 32-year-old male patient with diagnosis of schizophrenia present with complaint of hearing voices. He says, I can clearly hear two people talking about me. There's a male and a female voice. So their number and the gender is clear. Men sounds like an unknown older gentleman with soft pitched, whereas women has a young and high pitched sound. So tonality, pitch, and the unknown familiar voices is clear. Voices are very clear as though real people are speaking in the room, which is shows the clarity of the voice. They are perceived as coming from outside several times a day, especially when I am alone or in a quiet environment. They can last for 15 to 20 minutes per episode, sometimes may feel continuous. So frequency and duration is there. They are loud and demanding, making it hard for me to concentrate. They are very critical. They are calling me a failure and useless. So intensity and content is also shown in this example. Patient feels anxious and distressed due to the accusatory nature of the voices. He avoids going to any social situation, stays in his room, and sometimes talks back to the voices. I try to argue with them, but they just laugh at me. So the affect, behavior, and functionality of the patient is being described here. They just come and go whenever they want. I can't make them stop no matter whatever I do. So there is no exercise control over the voices. I think these voices are sent by someone trying to manipulate my mind. They aren't just in my head. So the insight is absent in this patient. This is a very simple example. Based on this, you should know what are the questions you should ask the patient while you're taking history or while you're examining the patient. All right. So in summary, perception is the process of interpreting sensory input to create a coherent understanding of the environment influenced by sensory, cognitive, and contextual factor. Disturbances include sensory distortion and sensory deception. Hallucination can occur in any modalities. There are certain special kind of hallucination, as we know, autoscopy, extracampine reflex hallucination, and they should be assessed for their modality, clarity, content, frequency, where they are located, if the insight is present, how are they affecting emotionally and behaviorally the patient. And this is very important in the clinical relevance is that you should be able to differentiate between whether a organic condition is there or a psychiatric condition is there, and proper management can be there or not. All right. These are your references. As you all read Fish and Sims, this psychiatric resident handbook, which is of AIMS, first edition this year has come. It has given very in brief how you should examine the hallucinatory part. Okay, so go through it once. Thank you. Any questions? So,